They say a healthy person has 1,000 wishes, but a sick person has just one. And of course, this is true, and it depends on what kind of sickness you have, I guess, as to what that wish is. So, for several years, a few years ago, I was just in this very strong pain every day that painkillers didn't work for. And sure enough, yeah, my only real wish was to not be in pain. But I do remember earlier, like in my late 20s, where I was just so exhausted all the time. I had severe fatigue, and yeah, my only wish then was to have more energy. And when you don't have energy, it's everything. It's all that you care about. And so, I tend to share things in this podcast that I think will be generally helpful to people, but sometimes I'll share as well from my own personal journey. And as I said, in my late 20s, I had really severe fatigue, and then I overcame it, and I felt a lot better, and changed my life, set up a business, started traveling the world, and really turned my life around, and it was great. And so the last few years, as I've recovered from that pain condition I just mentioned as well, I've been testing very regularly to see what's going on with me, and generally test results came back really, really positive. And the reason why I found Dr. Perrin, who is the person who I'm interviewing in today's episode, is because when I was working with Dr. Miriam, a frequent guest on this podcast, she suggested doing a mitochondrial function test. And I did that, and my mitochondrial function was actually way worse than I thought it was. In fact, it was at a level where, they were like, this is what you'd expect for someone who has chronic fatigue. And I was like, wow, okay. And I was like, I don't have chronic fatigue because, I remember what it's like to have that, and it's really bad, and it's not what I'm going through now. But I was like, yeah, maybe a mild fatigue. I'm still not optimal compared to what I would like to be. And so I was like, okay, let me look into this again. It's been 10 years. Let me see what's out there that, is the most effective for this. And I did a bunch of research, and I even did an episode about it a few months ago with a lot of, the most effective fundamental and some of the most cutting edge strategies. And stuff that had helped. Like already, even in the last 6 months, I'm feeling a lot better than when I last had this mitochondrial function test done. I will do it again soon, and I'll report the results on an episode forthcoming to let you know if the benefits shows on the tests. But anyway, I was looking for what's most effective, and I came across the work of Dr. Perrin. And I read his book, which I mentioned several times in the interview, and I was really blown away at how good it was, how aware and not dismissive he was of a lot of other modalities, as well as having come up with his own. And you'll hear in the interview that he really, bucked against the trends of what was believed possible in science. A little bit like Wim Hof. Wim Hof kind of rewrote the rules of medical science to some degree, and Dr. Perrin is maybe not as well known yet. I hope he gets his the attention and the awards and the recognition that he deserves. But he came up with some very interesting ideas about what the causes of fatigue. And so, obviously, if you have fatigue, this is worth listening to and watching. If you have long COVID, same thing. But even if you're like I was, not really someone who identified as having fatigue, but someone who, I could do with a bit more energy. Maybe you think you're just getting older. I mean, that's the thing, I'm 45. Maybe I just thought, you don't have boundless energy forever. But actually, there could be more to it. You could well, if you struggle to keep up, especially if you're the kind of person who tends to overdo it and push yourself really, really hard, you may well be in this position, and this interview may well change your life. So definitely recommend paying attention, taking note, and following up if this is something that you identify with, or if it's not, but you're a practitioner or something, consider it for the clients and patients that you have that suffer with this particular issue. So remember to like, comment, and subscribe. And please remember to share this with anyone who you think would find it valuable. So let's get into it. So, Dr. Perrin, welcome to the Rejuvenate podcast. It's a pleasure to have you here today.
Thank you very much for inviting me, Owen.
So I'm very excited about this interview. Your kind of breakthroughs in your technique is something that I've had personal experience with now for the last 6 months, and I found it to be excellent. I also read your book, The Perrin Technique, about 6 months ago, so it's not completely fresh in my memory. I was just flicking through it earlier to remind myself, but it was a fascinating book, really excellent. The best thing I've read on the subject of chronic fatigue for a very long time. I definitely recommend to anyone who has chronic fatigue, it is worth reading. But yeah, let's start with that, Dr. Perrin. Do you mind telling us about your background and why chronic fatigue? It's one of those niches that often is, what's the word? Not as taken as seriously as some areas, and it's kind of a thankless task, I guess, is what I'm getting at. So, what led you to helping people with chronic fatigue?
Yeah, well, when I started, it was 1989. So in those days, it was called the dreaded yuppie flu. That they reckoned, doctors, that young professionals were getting this, sort of like burnout, and they'd been too stressed in their office, and what they needed to do was just get out and play football or get out of the office and do something outside their work, and they used to drop like flies, and they were. And the doctors viewed it as a form of depression in those days, and they thought it, and the psychiatrists run the roost. And in some countries, it's still the same today. In Britain, we've moved on a bit with NICE changing the guidelines a few years ago, which I hopefully was involved in some way, because I was at the initial meeting when I told NICE that chronic fatigue syndrome affects everybody differently. You can't put everybody in one size fits all approach. Everybody's different, and one thing that I've been advocating for years is pacing, where they now have that as part of the protocol. But
Can you
the
explain what
thing
that
is,
is? Pacing?
pacing, well, I developed the half rule, the 50% rule, of doing half of what you feel capable of doing. And I developed that very early on to avoid stressing the body. So how did I get involved in it in the first place? Well, in 1989, I was very involved in sports medicine. I had a practice in the centre of Manchester, where I was treating top sportsmen from all walks of life, Manchester being a very sporty city. But one of the things, besides the football teams, which I won't go into, they also they had the top cycling team, and at that time, before the Sky, was the Rally Banana team. It was the leading team in Britain for road cycling, and I used to treat the Rally Banana cyclists, and they were called Rally Banana because they used to all wear yellow, which I always say is quite good, because if they were if they were cycling in the Tour de France, people might think they're the leader. So one of the Rally Banana team had ME, and he came in to see me with back problems and postural problem, which is very common with cyclists, road cyclists. And he came in for that, but he also told me he had ME. And I had one lecture, I think, when I was in the British School of Osteopathy training as an osteopath, and he was telling me about his chronic fatigue, and I thought it was a more psychosomatic disorder, that, smile at the patient, tender loving care, and everything's fine. So I said, I can help your back, I help your posture, but I didn't think I could help his ME, and I didn't try and help his ME in any way. I just wanted to get his posture working better and his spine working better. And I did, as an osteopath, using techniques that I'd learnt, and also developed different types of treatments based on my intuition and also my knowledge of the body, working on the fascia, working on the getting the blood flow working, and also getting the lymph drainage working as well, which was always important in the osteopathic world. even though a lot of osteopaths don't think of it. I always used to add a bit of lymph drainage to my treatments, and sure enough, this patient started improving. Now, it was mostly due to the fact that I thought I'll stimulate circulation, get the blood flow working, get the blood draining away, getting the muscles working, getting the soft tissue working, and his symptoms, his back pain went, which is what he came in for, but amazingly, his ME symptoms disappeared. And they went bit by bit by bit, but eventually, after a few months, he was completely symptom-free. And he said to me, "You've cured me." And I said, "No." So I said, "No, I can't cure that. I'd treat that. That's if it has helped you, I'm very happy." So he said, "It has." And he gave me a whole wad of notes and research papers that he'd collected over the years, trying to get better from his ME that I'd had for years. And I started looking through it all, and I thought, "Oh, this is interesting." And I realized that ME is really a form of what we used to call in the osteopathic world years ago as sympatheticonia, a problem of the sympathetic nervous system, which is now more commonly known as dysautonomia. So in 1993, I wrote...
And sorry, just to clarify, you're using the term ME, but a lot of our viewers are US. I don't think that's used commonly in the US. So by ME, you mean CFS, right?
ME/CFS, chronic fatigue syndrome. Internationally, it's known as ME/CFS. ME stands for myalgic encephalomyelitis. Myalgic being muscle pain, myalgia, and encephalo being to do with the brain, and myelitis being to do with inflammation in the spinal cord. Some people don't have inflammation in the spinal cord, so ME for them stands for myalgic encephalomyelopathy. Unfortunately, there's books out there, and even the British NICE guidance use the term myalgic encephalitis. They miss out the myelitis totally, so they don't even think about the spine. But if you understand anatomy and physiology, you cannot talk about the brain without the spine. The spinal cord is an extension of the brain. Everything that happens in the brain affects the spinal cord. So the idea of inflammation in the brain and not the spinal cord, or trauma affecting the brain and not the spinal cord, or vice versa, it doesn't exist. They all affect each other. It's a central nervous system. So I came up with a hypothesis. It was a working hypothesis that ME was due to, or chronic fatigue syndrome, ME/CFS, was due to a disturbance of the autonomic nervous system, because the symptoms that this guy seemed to have were symptoms of dysautonomia, of the autonomic nervous system not working well. He had his perspiration changed. He had heat temperature problems. He had problems with his heart. His heart was racing. He had all sorts of problems that we can associate with the autonomic nervous system. So that was my original paper. In 1993, I wrote a paper looking at ME from a biophysical perspective. And I said that what ME is, and ME, chronic fatigue syndrome, is a disturbance of the autonomic nervous system due to postural problems or trauma to the spine that affects the nervous system in some way. And this will affect the autonomics and cause a problem in the blood flow and and cause these overall symptoms. Now, it wasn't the lymphatics so much then, because I was always taught the lymphatics haven't got a neurological supply. They're just tubes. And these tubes are squeezed along by muscles or blood flow that squeeze along all the different tubes. And they're just inert tubes. And that's what we were taught. That's how physiology was taught in my day. And there's no neurological supply. There's no pumping of the lymph. It's just tubes. And this can't be further from the truth. In fact, it really surprised me when I started looking into it more, that the lymphatics were discovered by Aselli in the 1600s, Italian, and that was a long time ago. And all that time, people thought they were just tubes. and they weren't actually controlled by nerves. They didn't have any valves. They didn't have contractions. They just were tubes. We know so much now. We know they've got valves. We know virtually every single lymph vessel, all the collecting vessels, the tiny vessels under the skin collecting the lymph, have got smooth muscle walls with autonomic nerves, with sympathetic nerves attached to them. So they contract, and they contract along, all the way along, eventually into the blood vessels underneath the collarbone over there. Most in the left side, some in the right. But these tubes are not just inert tubes squeezed along by blood vessels or muscles, like we were taught that tubes of toothpaste just being squeezed along. These are active tubes that are controlled by the autonomics. And when the autonomic nervous system goes wrong, when you have this dysautonomia, instead of pumping one way, it pumps backwards and forwards, and they get bigger and bigger and bigger. And this was discovered not by me with the word of ME, it was discovered by me, but this was discovered in chronic illness by a Professor John Kinmonth in London in the 1950s and 60s. He did work with a guy called Browse, who was a neurophysiologist, and the work that the main duct of the lymph actually pumps at a beat of 4 beats a minute. Average beat of the thoracic duct, the main duct that goes in from the tummy up to the subclavian vessel in the left side. It goes all the way up. It's controlled by sympathetic nerves pumping along, but it has a movement of around 4 beats a minute. So when I learned this was phenomenal. But I also
and this was discovered in the 50s, and yet some people are still being taught.
We were never taught that. My lecturers were taught by people who might have been trained in the 50s. They taught me. I was trained in the 80s, so they might have been taught. They weren't taught this at all. And what also wasn't taught was that the lymph drains from the brain. Cerebrospinal fluid drains into the lymphatics. So this is a whole new area. And this was discovered many years ago, going right back to times of in the 1800s. There was William Cruikshank in Scotland, and there was Mascagni in Italy, who discovered that in the 1800s that there was possibly a drainage of the brain. But Andrew Taylor Still, the founder of osteopathy, talked about the waters of the brain draining to the lymphatics. Now, all this was just theory. There was no absolute, and then there was a Russian Speransky in the 1940s that did research into this drainage, and there's there's been other scientists in the UK and in America looking at the drainage of the brain. But to the end of the day, is all these areas were just theory, that there must be a drainage from the fluid of the brain and the spinal cord into the lymphatics. Why must there be? Well, that was a big question mark. Why? According to the rest of the world and how I was taught, there was no drainage of the brain or spinal cord at all. There was no need for a drainage of the brain because there's the blood. The blood drains off any toxins in the brain. We don't need a lymphatic system. So then you have to start really examining the lymphatic system. So I spent years and years. I went to the University of Salford and I spent 11 years doing part-time research. And one thing I learned, Elwyn, there's no such thing as part-time research. I was doing a full-time job as an osteopath, and I was doing a full-time research when you're doing, and I had to juggle both with a family and everything. So I think my family lost out and hardly saw me. But and those were the days before PCs, before we had computers. So legwork was legwork. Was going up and down stairs in Manchester University Library looking for evidence. And but the thing is that I said there must be a drainage system of the brain into the lymphatics, which was completely against medical and scientific thinking. And I realised these great scientists and doctors of the past were right. There has to be. It was so obvious to me. And nobody else was talking about it, but it was so obvious. And the obvious fact I will tell you now, and you know it because you've read my book. First of all, why did the rest of the world say there's no such thing? And I did my whole research that ME is chronic fatigue syndrome is a disturbance of this. This is actually a disturbance of this drainage system. So if this system is disturbed, it's not working properly, and then it goes the wrong way rather than the right way. Instead of going along in the right way, pumping it out into the bloodstream, it's pumping backwards, but pumping up into the brain, pumping toxins back into the brain. But that's only if there is a lymphatic system of the brain. Why did people say there wasn't? Very simply. You need the lymphatics to drain away large molecules. That's why we need the lymphatics. The blood can go through, toxins can go through the capillaries of blood. Large molecules can't get in, but small molecules can. The large molecules need the lymphatics. The lymphatics, their capillaries, have walls like gills of a fish really, and they open and close and allow huge molecules to enter. They go through the lymphatics and eventually end up in the major blood vessels there, and then they go into the blood and eventually into the liver. So the question is, why are there no large molecules in the brain? Medical science for years theorized about a barrier, the blood-brain barrier. And in the
Blood-brain barrier, yeah. I think most of our viewers have probably heard of that, yeah. This idea that it keeps everything out, or almost everything out.
It's got tight junctions that stop any large molecules getting in. These tight junctions form a barrier to any large molecules getting in. And this stops any large molecules getting into the brain, and therefore we don't need a lymphatic system because the blood can cope with the small molecules. Water being only 18 Daltons, very small in the size of a molecule measured in Daltons, and John Dalton came from Manchester, so I always wave the Manchester flag. But so 18 Daltons can get through the blood-brain barrier. Water is very small, and water molecules, anything water-based, can go through water carrier systems called aquaporin, and that helps the fluid get particles get into the blood-brain barrier and out to the blood-brain barrier. But huge molecules that can't get into these aquaporin channels, they can't get through because there's this barrier. So therefore they don't need a lymphatic system. Very simple. So the idea that the lymphatic system is going wrong from the brain, causing a condition, so that didn't sit very well with all the scientists and doctors I spoke to, and I had neurologists walking out of my lectures. And also, this causes a disease that most people in the 1980s and 90s and the early part of the 2000s, so all that early years of my work, they were totally disbelieving that the illness existed. But I was amazed that the University of Salford gave me a doctorate in a hypothesis that was based on something that didn't exist, on a condition that didn't exist. That was quite amazing. Because when I published my thesis in 2005, so it's basically 20 years ago now, and I published that, this was completely against medical thinking still. There was no evidence, no proof that this drainage system existed at all. But Salford, yes, gave me a doctorate because we did research and we showed my treatment helped based on my thesis, on my hypothesis, but the hypothesis was flawed when you talk to any scientists at the time and doctors at the time. They said, this is just nonsense. So, move on.
So tell us the resolution then, yeah.
The resolution. How did I know that the drainage was that? Why did I know I was right? First of all, I was using this idea to treat the patients, but then I just thought, who gets ME, who gets fibromyalgia, and now long COVID. I've got my new book on long COVID, which came out last year. I don't know, I've got this there, so I plug my book. That's so that's
And sorry, actually, before you continue and reveal to us, just a quick side thing. Okay, so this interview is obviously relevant for anyone who has chronic fatigue or wants to help people with chronic fatigue. We've just said it's also helpful for anyone with long COVID or anyone who wants to help people with long COVID. Is this relevant to the general population, people who don't suffer from any of those kind of issues?
Well, this is the thing. What I've discovered, a lot of doctors and scientists have said, you're selling yourself short there. Perrin Technique can help so many different conditions, and also can help things like prevent diseases and keep the health of the brain working. And I know you're very much into longevity and keeping youthful. I'm 65 now.
I was going to say, you don't look 60. Like when you said you trained in the 80s, I think most
do the
people
Perrin
watching,
technique.
would be surprised. So you've had your technique done on yourself frequently as well, and you've trained.
I know I teach it, so I show how to do it. But no, I wouldn't say it's that's keeping me. I think I'm just chose my parents well. My hair. My dad was 92 when he died, and he still had a lot of his own colour. And my mum had very healthy hair as well. So I genetically am. Yeah, I'm now. I've just been made the university in New York Institute of Technology have just awarded me a professorship. So that's nice, and I should be white-haired professor. I'm still. I might be absent-minded, but so I'm attached to the university now, and it's
not just your hair. Like if you'd have told me you were 45, I would have believed it. It's quite impressive. So that maybe you're into healthy lifestyle in general is the impression I get from your book.
Well,
So
I also it's a healthy mind and healthy body. I try to always keep positive about things, and I think that's very important. That I was taught that at an early age to always look at the bright side of life, as the Monty Python song goes. Anyway, so on to this.
Sorry, back to
why? Yeah, and the one
just
thing.
Can we finish? Like, what other things would it potentially be helpful for? And you can make it as potential as you like if you're not sure.
Other things it can be helpful for are fibromyalgia, definitely. 100%. We've helped a lot of people with fibromyalgia. We have helped other neurological conditions, but we haven't done research into it. So every other neurological condition does have a lymphatic component. So if we can help the lymph in the brain work better and the spinal cord work better, we can help a lot of neurological conditions, maybe all. We can help Alzheimer's, which has definitely been linked to drainage problems of the brain, where you've got beta amyloid and prions. Beta amyloid and not prions. That's with CJD. But CJD, that's Creutzfeldt-Jakob's disease, has been linked to problems of drainage of prions. But with Alzheimer's been linked to beta amyloid and also to there's another protein molecule which has also been linked to a drainage problem. I'm sorry, my mind's gone. Yeah, I have to do more drainage.
No worries. Beta amyloid's enough. Yeah, that's the main one you talked about.
It's the main one. There's also there's protein molecules get stuck in the brain, causing the Alzheimer's to form, and you get these plaques. So if we can actually help drain those large molecules away, that will be their goal, and it's the lymphatics. And just this year, there's a new study done by China showing that they've found a treatment that helps with Alzheimer's, and it's massaging down the neck.
I saw that. Yep.
I thought reinventing the wheel. I hope they've actually referenced my work. I haven't looked at the paper yet, but I will.
I saw there was even a surgical thing they did of helping the drainage or something.
Anything to help the drainage will help these diseases. You have. So if you have a build-up of these protein molecules, you are going to have a major effect on many conditions. And if you can help drain it, you can help reduce those conditions, those symptoms. So we can help a lot of things, but we haven't done the research. I've spent my last 36 years researching into ME, fibromyalgia, and now long COVID. So those are the ones I can say we've got evidence to support it.
So
But
before I
the thing is
interrupted, yeah, let's go back. So it's the blood-brain barrier. Why were you right that there is a lymphatic system drainage from the brain? What was the resolution?
there has to be, and the reason why is you look at who gets these conditions more than men or women, male or female, and we know it hits the female population much more than the male population. And the question is why? And the answer is very simple: hormones. Hormones are the big issue. And with other things we can help now, a lot of people get talking about other conditions. One of the main conditions we are helping a lot of is when people who have lymphedema and lipedema, or lymphedema with lipedema, they often have a condition that actually has got a term now. It's called gland syndrome. It's this lymphatic system with generalized lymphatic problems associated with nervous system problems, with central nervous system. And this is what most people with lymphedema don't even realize, that it's not just their legs that get swollen or arms get swollen. If it's primary lymphedema, they often get a lot of problems in their head, concentration problems, they feel muzzy. So they have very similar symptoms to people with chronic fatigue syndrome, and they never realize there's a connection, but we put it all together and we realize that we can help these patients as well. So there's more and more conditions that we're starting to help. So lymphedema and lipedema, when they've got neurological problems affecting the central drainage, then we can help them as well. So the thing is, it nearly always affects women, secondary lymphedema, and it affects them during puberty or during menopausal times, or after pregnancy, where there's hormonal flux. So the hormones are a major part of the whole problem. A lot of people we see with ME, it's during it with chronic fatigue syndrome, and fibromyalgia, it's during puberty again, or menopause or perimenopausal, but mostly women more than men. We do see male patients, as you say, as I think you had the condition yourself, didn't you?
I think it was mild when I did that extensive assessment, but I thought I would try it anyway.
It does affect, but again, it can affect a lot of young teenagers during puberty. It can start affecting them then. So the hormones are a definite link. And what controls the hormones in the body? The hypothalamus. And then I remembered learning, when I studied, I was quite a studious student, and I remembered studying physiology all about the hormonal system and how hormones are controlled and regulated by the hypothalamus. We also talk about the HPA axis, the hypothalamic pituitary adrenal axis, but it goes much more than that. The hypothalamus controls every single hormone via pituitary or via other areas. It's not just the pituitary, but you have the hypothalamus controlling, regulating every hormone in the body. Let's take insulin, which is one I always use in my lectures and my book. Insulin is a huge molecule. It's 5,808 daltons. Remember I said the water molecule is only 18 daltons. It can get through the blood-brain barrier, get through this very small spaces, very small gaps, these connections. So these gaps are the tight junctions are very tight. They're called tight junctions because they're very tight and only very small molecules can get through. Something 5,808 polypeptide molecule like insulin cannot get through the blood-brain barrier. But we know it does. We know insulin has in the hypothalamus has insulin receptors. So it measures, this is how it controls the hormones. It measures the hormone. It sends messages via autonomic nerves back to the pancreas, which is in the tummy, and in the abdomen, and it sends messages back to then say to the pancreas to produce more or less insulin. This is known as biofeedback. And this is how the hypothalamus regulates everything. It regulates the hormones by this biofeedback mechanism, and it balances everything. That's the job of the hypothalamus. So once I realized that, I thought, wait, insulin, so huge, gets into the brain. How? The blood-brain barrier mustn't be a very good barrier. It must have gaps, especially in the hypothalamus. And now we know there are 7 circumventricular areas in the brain. These are the gaps of the blood-brain barrier that allow hormones in, that are huge. There's the pineal gland, there's the posterior part of the pituitary gland, there's other areas, there's areas that let electrolytes in. So the subfornical areas of the brain that allow electrolytes in. These are all gaps of the blood-brain barrier. So the blood-brain barrier is not a very good barrier at all. That's first of all. And since it allows these huge molecules of hormones and electrolytes, salts and sugars into the brain, then it can also allow toxins in. And it does. In the droves, toxins will come into the brain willy-nilly and end up in the glial cells of the brain, packing in and causing mayhem, causing inflammation, causing neuroinflammation. And I said that this is happening with ME. If it doesn't drain away the lymph, we have to have a lymphatic system to drain that away. There has to be a lymphatic system, and that's the cerebrospinal fluid. And this was the theories right back to the origins of osteopathy, where Andrew Taylor Still, the founder of osteopathy, in the 1870s, he founded osteopathy, and he said the waters of the brain drain to the lymphatics. Most people have heard of cranial osteopathy, and one of his disciples, William Garner Sutherland, developed the whole concept of cranial, and he said the same thing, that lymph drains from the waters of the brain, and this is a major part of the cranial treatment when we actually stimulate the drainage of the brain. So this was part of the origins of osteopathy. But that was before they found there was a blood-brain barrier. So nobody knew about the blood-brain barrier then. It was theorized. And in the 1960s, it was proven with electron microscope. They proved that the blood-brain barrier existed. And therefore, this idea of drainage of the brain didn't exist because there was a barrier. Nobody knew about the gaps in those days. Nobody thought, well, how does hormones get in? I don't know why they didn't. But obviously they didn't.
It's one of those things that sounds obvious when you say it, but...
So I said there must be, and this drainage system, it needs to work in a good way. If there's this backflow that we knew from Kinmont's work, this backflow can go back into the brain. Surely. If there's drainage out of the brain through the lymphatics, through cerebrospinal fluid, and it goes into lymphatics, it must go back. And Speransky talked about the cribriform plate, which is a bony plate, which is part of the ethmoid bone above the nose. And it stays above the nasal passages. And this cribriform plate allows olfactory nerves to go through for smell. But next to the nerves, there's blood vessels. And the blood vessels have a space around them called perivascular space, or also known as paravascular. They're slightly different, but for the talk, that's going into the depths of neuroscience. But the space around the blood vessels contains cerebrospinal fluid. This was my theory, based on the work of Speransky and the work of Kinmont, and the work that we found also, not just in Kinmont's work, but also the work of Andrew Taylor Still, talking about the drainage of the brain from into the lymphatics. So as an osteopath, I put everything together and then formulated a theory that then was more than just sympathetic nerves going wrong. It was sympathetic nerves controlling the blood vessels, yes, but also the lymph drainage. So if the autonomics weren't working properly, it caused a backflow, which caused toxins to go back into the brain. And my theory was that this was happening mainly through the cribriform plate area, going into the hypothalamus, which then had a problem because it controls the sympathetic nerves, the autonomic nervous system. So then it created a vicious circle, a cycle that just created more toxic backflow because it wasn't pumping the right way. So that caused more drainage into the brain. That caused the hypothalamus to work even more dysfunctionally, and the sympathetic nerves that drive the movement of the lymph to go even worse and worse and worse. Eventually, when so many toxins build up in the brain, it affects different areas, and there's 100 billion neurons in the brain. 100 billion, and they're all connected by synapses, which have chemicals in which are affected by different toxins. So toxins can come in all shapes and sizes. What the main toxin that triggered this condition, the final trigger, was usually a virus. And the virus produced a reaction, immune reaction of when you have a virus, your body produces cytokines. Cytokines are large protein molecules that are usually pro-inflammatory, that are signaling molecules to your antibodies saying, "Cooey, here we are, come and attack us." They attach to the virus and then your body attacks. These cytokines, interleukins, interferons, are used, people know about, are used in chemotherapy for treating cancer. They'll give you a massive load of cytokines that attach to the cancer cell and your antibodies will kill the cancer. This is how most chemotherapy drugs work, and this is the same what's happening in our bodies all the time. We have cytokines being produced when any virus or bacteria or any foreign body hits us, we get this cytokine production. Now those cytokines are large protein molecules and they need to be drained away. And what drains away large protein molecules? The lymphatics. So if there's inflammation building up in the brain, we need the lymphatics to drain away these large protein molecules in the brain. And this was part of my original hypothesis, that the ME was not caused by a virus, but triggered mainly by a virus, by a cytokine storm, that a huge cytokine overload that caused neuroinflammation, that affected the hypothalamus more and caused more dysfunction in the autonomics, which caused more drainage problems of the sympathetics and of the lymphatic system.
Genetic Insights provides cutting-edge, affordable DNA testing, giving you access to over 500 health reports that can help you in 3 key ways. They may be able to resolve your existing health challenges even when nothing else has worked. Using simple lifestyle changes, their reports can help you reduce your risk of developing future health challenges that you may be genetically predisposed to. And they can help you feel more confident in your health by showing you where you are genetically strong. Unlike most other genetic health testing companies, Genetic Insights tests over 83 million different variations in your genes, guaranteeing 99.7% accuracy across all of their DNA reports. They cover almost every aspect of health, including digestive issues, cardiovascular health, weight loss, hormonal and blood sugar balance, as well as nutrient needs, allergies and intolerances, and so much more. Using their system is quick and easy, and reading the reports is simple. If you've done an Ancestry DNA test, you can simply download your raw DNA data, upload it to the Genetic Insights platform, and within a few hours you will have access to genetic reports which give you a risk score for each specific issue and scientifically validated recommendations based on your individual genetic profile. Everything in your reports are based on scientific studies, and there are citation links throughout every report. If you are serious about optimizing your health and wellness and feeling great, then getting access to your Genetic Insights reports may be the most important health investment you will ever make. In the reports, not only will you gain insights into how to overcome existing health challenges and avoid future issues, You'll also discover which types of dietary, lifestyle, and even supplement protocols are best for your unique genetics. To get your unique genetic health reports, go to geneticinsights.co and use code REJUVENATE to get 20% off today. That's geneticinsights.co using coupon code REJUVENATE to get 20% off today.
Basically, this was my original hypothesis that I put down in paper in the 1990s, and we did research to look into this. But also, the ME is not just the brain. So much has happened since this. This is just giving your viewers an idea of what was going on in my mind, how I was thinking all those years ago, 30 odd years
Well,
ago.
can I ask a couple of questions on that before you move on to the new research then? So one thing that occurs to me, a lot of the time when you see people with chronic fatigue, they complain that like it doesn't look like there's anything wrong with them. They often look quite healthy. Maybe their skin looks quite young. And then when they get blood drawn, they get told there's nothing wrong with them. Maybe they look healthier than the average person. So is this because you're saying the reason for this is because none of the tests that have been done are on the brain. So the toxicity is actually going out of the body, the rest of the body and into the brain where no blood's being drawn, no tests are being done usually. And so this is...
Exactly. And this has been shown by Jared Younger, that there's a massive amount of cytokine activity. And he's a neuroscientist like myself, because I'm a neuroscientist having a doctorate in this area. This is my field of my thesis. So Jared is in Alabama University, used to be with Stanford, and they did some amazing research looking at the cytokine profile of the brain in these ME CFS patients, and they found there was 17 cytokines stuck in the brain, very high levels of cytokines, including leptin. And leptin is an adipokine, a cytokine that's attracted to the fat cells of the brain, because the brain's very fatty, and that's what attracts a lot of these cytokines to stay there. But they weren't draining away. And the cytokine and leptin affects satiety. When you have too much leptin, you need leptin to give you an appetite, but too much and you just keep on eating and eat because it goes overload. It's meant to stop you eating, and if it overloads, it just stops working. So you just end up with a voracious appetite or no appetite at all. So leptins are very important to keep your weight levels right, but also to keep your satiety and hunger levels. But it's very much a female hormone. So we have two reasons now. One, hormones generally. The changes affect hypothalamus more in women because of changes, flux during monthly cycles and puberty and menopause more than men. And also leptin. Leptin is another reason why women get...
When you say leptin is a female hormone, I understood it, like you just said, as a satiety hormone.
Yeah,
so how is it a female hormone?
It's in both. It's in both male and female, but much more found, much higher levels in females. It's a very much more important hormone in females. So it's in males as well. But so this is another reason whereas what Jared Younger discovered, that leptin, as leptin went up and down, so did the symptoms of ME. It had leptin had an effect on all other cytokines as well. So it's like signaling other cytokines to form more pro-inflammatory cytokines to come into play. So it's a very important hormone, and this was discovered by Jared Younger and his team at Stanford. So this is a second reason why women get ME and fibromyalgia, and now we're seeing long COVID more. But the third reason is actually the body type. So a female patient will have we're talking about, this is where the drainage is, and the drainage should go down from the brain and the head down into this area, down the cervical lymph. And it should go up in the chest, in the breast, and up into the subclavian for the breast. So if it goes the wrong way, the first port of call is going to be breast tissue. And that breast tissue is going to get more and more congested as the backflow goes worse and worse. And who has more lymphatics in the breast tissue, male or female?
Women, female.
Yeah. So that's the third reason. It's actually a physical reason. And this is why women get these conditions much more, because of the backflow affecting the lymph, and then that will affect the nervous system more because it's being overloaded and being irritated, and you get so this is, again, we don't look at the lymph, we look at the blood, not the lymph. It's congested in the lymph. So again, the blood tests are not looking at the lymph, they're not examining lymph, not doing aspirations of lymph vessels, they're just looking at them. But the thing is, when you have this backflow,
I'm sorry, is there anything in blood tests that would indicate this is going on? Like different, levels of lymphocytes, or you just mentioned leptin?
There are some signs that even with all this going on, sometimes the lymphocytes will go wrong, and sometimes the toxins will get so much they'll spill over into the blood system as well. So we are looking at cytokine profiles in the blood, and maybe there are ways and means we can test the blood and see what's going on. This is early days of looking at this area of research, and we'll be doing more. I'll talk about that at the end, about the research we're going to be doing, and we're just about to embark on a major research project. But going back to what we now know, since I made this hypothesis that this was what was causing ME, that there was a build-up, and it wasn't. So what was causing this problem in the first place was a drainage system problem. And if you have trauma to the head in any way, it could affect this drainage system. And trauma to the spine in any way could affect the drainage system. So that could be the start of the whole journey into the wrong direction. Just postural problems in the spine, or physical problems in the head and spine that could lead to this.
Okay.
So
that could be a root cause. Just a blow to the head, it starts the toxins going in the wrong direction, then that dysregulates the brain, then everything goes wrong.
Yeah, or it just stops the drainage occurring properly, and then there's a build-up, and then that causes the sympathetic nerves to start working wrongly. So as an osteopath, we looked at the structure of the body, and I noticed that every single patient who I saw had major structural problems of the spine. The thoracic spine was never the normal shape, and it was very flattened, and there was curvature problems in the top part of the back. And this I saw again and again and again. So this was the first thing I wrote about in my 93 paper, saying that there was a spinal problem in the thoracic spine affecting the sympathetic nerves, but it was more affecting the drainage, which I then learnt about. So then we go on to a few years on, and my thesis was published. I got my doctorate, but we had no absolute proof that there was a drainage system problem of the brain, because we didn't know there was a drainage of the brain into lymphatics anyway. But I may have one or two major discoveries when I was doing my research by examining the patient. So I found 5 physical signs. The spinal problem was one in these patients with ME, fibromyalgia, chronic fatigue syndrome. Another one was the varicose lymph, that the lymph were going in the wrong direction. So when it pumps wrongly, it doesn't cause lymphedema, where sometimes it can, but mainly it doesn't. It just caused the lymph to swell up. And as I said, John Kimmett discovered that in major diseases, there's these varicose, or what he called megalymphatics. So in many diseases, there's these megalymphatics, but he couldn't prove their existence. He took he took X-ray images of these using an adapted form of angiograms, lymph angiograms, and people saw these vessels were swollen, and they said, "Very nice veins, John." He said, "No, these are not veins, these are lymph," and he couldn't prove it. Then I took a photo that actually is in my books and everything, it's in my work, which when I first showed it to a conference, a professor from America came over and said, "Gee, that's an amazing image. What did you use to get this incredible image?" I said, "A camera." He expected it to be some huge high-tech machine, and it was just a camera. And this image was the first photo ever of varicose lymphatics, and I have it in my book, so I can show it on the screen now because it's very easy to see. And the most important thing about it is just get it now.
So varicose lymphatics is a swelling, expansion of the lymphatic vessels?
Expansion of the lymphatic vessels, similar to a varicose vein, and but it's actually here. So these are the varicose lymph. I don't know if it can be seen. If I can show it there. You can see that? So this is a chest of a man, and it's underneath the collarbone. You can see these very large vessels. And they're not blue, they're not green, or greenish, some people say. They're not blue or purple. They're the same colour as the skin tone. So they're coloured because the fluid in those vessels is colourless. It's not got deoxygenated blood, so they're not veins. Varicose veins are usually bluish, purplish, but they're not discoloured. These are not coloured. So the only vessels that have no colour in them in the body are lymph. Lymph vessels don't have colour in the skin. And these vessels, you can see them really clearly. They're about 0.5 centimetre wide when you actually fill them usually. And that one there I showed was about 0.5 centimetre wide. They should be 0.5 millimetre wide. These are lymphangions in the subcutaneous fascia, should only be 0.5 millimetre wide. So we're seeing them 10 times the width because there's a backflow causing this. So this was proof positive of Kimmont's work, finally proven that there were varicose lymph, and I showed this in ME. So every single patient, we don't see it, but we can feel it always in the chest. It's a first port of call when there's a backflow in the chest. So this we feel, and in male and female patients, we can feel it. Now, when I was examining the patients for these varicose lymph, I noticed the third sign. And I got to the left side, I started on the right side, I went to the left side, and when I got to a certain point in the left side, it was tender. And you'll have people watching this starting to feel them, and they often can feel it. At the side, it's left superior, it's just slightly superior to left nipple area, around this area here. You will feel a tenderness. And this eventually got termed Perrin's point. Now this point took me a long time to work out what was going on there. But with my knowledge of neurophysiology and neuroscience, I managed to work it out. And basically, sympathetic nerves which are being irritated in the thoracic duct. The thoracic duct turns to the left side, just above the nipple line, and it goes up into the left subclavian vein. And during that, if that's being irritated, sympathetic nerves are going to fire off, and they're going to come close to the surface of sympathetic nerves and irritate sensory nerves that go alongside them. Sympathetic nerves, when they come to the surface, go alongside sensory nerves, and the sensory nerve is a much bigger, wider nerve than the sympathetic nerve. So I'm using this as a somatic sensory nerve and this finger as a sympathetic nerve. When they're close together, there's a crossover of messages from axon to axon, from the nerve cell to nerve cell. Not synapses, as we all know about, synapses. These are called epapses. And this, the idea of epapses was talked about in the 1950s by a chap called Gasser. So again, this was research that had been done, anatomical findings that had been done, and we were never taught about that in osteopathic school. Doctors are never taught about these epapses. So when these sympathetic nerves get irritated from the thoracic duct, they irritate the sensory nerves in their surface. But why just one point more sensitive than others? And that's because of the other element, the heart. In the American Civil War, there was Da Costa, Jacob Mendes da Costa was a doctor in the American Civil War in the Union Army. he discovered that patients were coming down with this, what he called irritable heart or soldier's heart, that they were overloaded, and it caused a problem of the nerves supplying the heart, the autonomic nerves, the cardiac plexus, which is deep in the left side. And that being affected caused a lot of tachycardia, palpitations, and caused a lot of problems in exhaustion. So he called it Da Costa. It was called Da Costa syndrome. Unfortunately, the psychiatrists usurped it all and eventually started calling it PTSD. And Kimmons became known as the father of PTSD. But it was he was saying it was the physical irritation of the nerves supplying the heart that was causing the problem. So these sympathetic nerves deep in the cardiac plexus in the left side of the chest get irritated when they come to the surface. When they come to the surface, they cause an irritation. They cause an irritation to the sensory nerves, another network. And where those two networks of sensory nerve get irritated, cross over, that's the Perrin's point there. So that's why we get this tenderness. And we see it again and again and again in ME, fibromyalgia, long COVID, we're seeing the same. And then we've the fourth sign is the celiac plexus, which is a solar plexus in this part of your tummy, just underneath your rib cage, in the centre, what we call the epigastrium. But this is called the solar plexus. Boxers know all about it because they can box your head, or they can go for your body blow and hit the solar plexus, and you can knock your sympathetic nervous system out. So this area gets very sensitized as well. And also that's the bottom area, that's in the level of where the thoracic duct, when it pumps the wrong way, pumps out. So it often is very inflamed in this area and it causes a lot of irritation in this area. So that's the fourth sign. The fifth sign is the cranial rhythm. This is osteopathic.
And sorry, what about the solar plexus is the fourth sign?
So that becomes very tender and inflamed in this area, and this we see when we feel the patient. And this is, again, always there. Sometimes it's very severe, sometimes it's not. We have different levels, but this will give us an indication that these patients have these neurolymphatic disturbance, the neurolymphatic problems like ME, fibromyalgia, chronic fatigue syndrome, long COVID. So then the fifth sign is osteopathic. It's the cranial rhythm. And when we do research, we always go to ethics committees. And we were doing research and we went to ethics committees on the physical signs. We did a major study in NHS on the physical signs. And they said, we understand all the other signs. We understand the science behind that. Fantastic. The cranial rhythm, we don't understand. We're not osteopaths. Explain that. So I explained it. And the explanation I gave was actually was part of a paper that I published in 2007. So 2 years after my thesis was published, long before the glymphatic system had been discovered, I wrote a paper and it was published in the American Journal on the cranial rhythm. And I said the cranial rhythm is based on physics, simple physics. The cerebrospinal fluid in the brain is produced by the blood. It's called the choroid plexus that produces cerebrospinal fluid, the blood, and it goes round the brain, down the spine, and goes back into the venous sinuses, into the blood. So it's produced by the blood and goes back to the blood. So in the brain itself, in the ventricles of the brain, if you actually measure the fluid, it would go according to the blood flow, according to the heart rhythm, the 50 to 100 beats a minute, the heart rate. So that is the rate within the brain. But now it comes out. And my theory was it came out into lymph. And Kimmons showed with Browns that the main drainage of the brain, of the lymph, the main thoracic duct, pumps up 4 beats a minute. So you have 50 to 100 beats a minute draining into a system that has the central drainage of 4 beats a minute. Very, very fast wave going to a very gentle wave. And that produces a third wave. Physics dictates that. It's called the interference wave. The interference wave can be easily explained to the layperson. You don't have to be a physicist. You just go to a beach. You see a big wave coming in, small wave going out. They crash together. They produce a third wave. In the brain, same thing. the body works on the laws of physics as well. So cerebrospinal fluid comes out from the brain, starting at the heart rate, going into the lymphatics, which has a rate of 4 beats a minute. It creates a third wave. And that third wave, I gave the figures to the University of Manchester's hydrodynamic department to work out the figures. And I said, could it be 8 to 12 beats a minute, which is the theory in the osteopathic camps? And they'd said unequivocally yes. So that became a paper that was published in the Journal of the American Osteopathic Association in 2007. 5 years before the glymphatic system had been proven to exist in mice. And do you know when it was proven to exist in humans? Last October.
Yeah, I was going to say, it's very recent, wasn't it? Yeah.
In October.
I didn't realise it was that recent.
Yeah.
Wow.
The actual lymphatics were only shown in real time to really exist. The proof of concept was only in Oregon. They took 5 patients who had brain tumours, who gave permission for them to look into the glymphatics because they had opened up their brain to remove the brain tumours. Whilst they did that, or afterwards, they injected a dye and watched what happened in real time. So these 5 very brave people gave their permission to do that, and it showed the glymphatics working exactly as we said, in real time, draining out. So it was only shown in 2012 in mice by Macon Nadergaard and her team in Rochester University in New York. Jeff Iliff was the lead author of that paper. They showed this in mice. They showed the actual drainage of the brain through these perivascular spaces, paravascular spaces, out of the brain, only in mice in 2012, and in 2024 in Oregon in October, it was actually published, the paper showing the glymphatics actually showed drainage during the in the brain of humans. In South Korea, they've shown that the main drainage is through the cribriform plate. That's just been last year. And last year as well, they showed there was a whole network of lymphatic system underneath the nose that nobody knew about. And yeah, a lot of my work...
Could this be another explanation why, like, you know, a lot of people have sinus issues, whether it's allergies or chronic infections?
Yeah, it's all that, that's why, yeah. It's all that. And this also explains why why the first symptom of COVID that they felt was anosmia, loss of smell, as the toxins went up there. But I predicted long COVID was going to happen. When you had COVID, we knew in SARS-1, which was 2003, a lot of patients who recovered, a lot of them died in SARS-1, but the ones that recovered, a lot of them developed ME, CFS. And they were, Harvey Moldovsky in Toronto led work and did autopsy work to show for the people that didn't survive that the toxins had gone through the olfactory pathway, so through the cribriform plate, into the brain and affected the hypothalamus, exactly as I said would happen if you have this backflow. So patients who get these diseases, if their drainage doesn't work properly, when they get hit by something like COVID, it's going to go up into the brain and stay there. So the COVID doesn't cause the long COVID, it's the final trigger. All these viruses that go into the brain are the final trigger. The cause is a backflow of lymph beforehand, and this is seen by the physical signs. We can see that the person's had problems of drainage for a long time. So the physical signs were, so I wrote the paper on March the 11th, 2020, called Into the Looking Glass, together with I wrote the initial paper and then collaborated with my colleagues at the University of Manchester to get it published. And this was called Into the Looking Glass, post-COVID-19 syndrome. We predicted this was going to happen, which is now called long COVID. So we said it's going to happen, and that was the day that the pandemic was announced. And it was the day of my anniversary. I always joke, and my wife allowed me to write this paper on the night of my anniversary because I knew it was so important to get it out there first. So March the 11th, 2020, I wrote this paper. It was published later on, I think in June. And then the rest is history, because we knew that this actually happened. And we said, beware, there's going to be millions of people with long COVID, because it's going to go through this pathway, affecting the nasal cavity and causing anosmia, affecting the olfactory pathway, going into the brain, affecting the hypothalamus, and then leading to full-blown ME. And that's why the book I've got, Through the Looking Glass, is that's actually happened now. And the evidence is really quite strong to show that the glymphatic pathway has been affected and causing this problem. And now we know that the glymphatics, Make Nedergaard termed the glymphatics, because it's lymphatics from the glial cells of the brain, exist in humans. But the question is now, for all the doctors who are and the scientists who are working this, what do we do about it? Well, 36 years ago, I worked out what to do about it. And I started my technique. And we stimulate the drainage using Cranial Technique.
Yeah, sorry. Let's get into that in a second. What do you do about it is the crucial thing. Just before that, I'm thinking about the long COVID thing. So would it make sense for everyone, or at least everyone health-minded, to do like an assessment to see if their lymphatic system is draining correctly, to see if they're predisposed to developing all these problems, even if they haven't yet?
You could feel your own body and feel if there's any problems there, and if there is, then you can get help. Yeah. And prevention. I'm the only person in the world, Elwyn, that says you can prevent ME. Since the world is still looking for the causes of ME, they're saying we don't know the causes. We do. Since they're saying we can't have any tests to actually identify it, we do. The British Medical Journal published my paper on the physical signs. We showed 86 in a blind control study, taking a whole group of people who had ME and a whole group of people who didn't. The people examining the participants didn't know who was who. And we had my practitioners doing it, and an NHS practitioner doing standard neurological examination, standard rheumatological examination, get him to stand and walk, and seeing if he worked out if they were ill. He got 44% correct, 56% of the ME patients, using his knowledge, and he was experienced, said they were healthy. We got 86% diagnosed ME with us in our study. So he was 44% and we were 86% using the physical signs. So the physical signs were then, so that was a paper that was published in the British Medical Journal in 2017. I was very touched that the British Medical Journal, the Doctor's Journal, published my paper talking about the cranial rhythm as though it's a given, which was really nice because I used my theory. So I think it was the first time that the British Medical Journal ever had a paper about the cranial rhythmic impulse, the osteopathic cranial rhythm. So it's quite exciting.
I can see you really do tend to focus on the positive, because I've spoken to other people who've discovered new things like yourself, and often they're very frustrated that there hasn't been more of a mainstream adoption yet. And you could be on this interview saying I could have prevented millions of casualties if people had listened to me from the beginning. But
because the physical signs are there. Physical signs are there before the illness. And this is what I'm saying. Sometimes it runs in families. The families, I've seen whole families with quite a few members of the same family with ME. It's heartbreaking. And doctors say, it can't run in families. Yes, it can. There's a scientist doctor in Spain, in Barcelona, Jesus Castro, who did a major study showing 15% of all ME CFS patients are familial, and sometimes 6 people in the same family can have it. And so genetically, you look like your parents because of your gene expression of your bones of your face. The bones of your cranium and the bones of your spine could be very much genetically linked as well. So it can run in families. There could be anomalies from day one, from birth, of drainage problems that start from as soon as you're born or before. So this could happen, and this could cause a build-up and eventually one final trigger. And it doesn't have to be a virus. It could be a trauma. It could be emotional trauma. It could be physical trauma. And I'm not going to be drawn into the whole debate about vaccines, but vaccines and the toxins that some vaccines had, especially in the old days, thimerosal with mercury, were known as a trigger for ME as well. This is in a Canadian criteria of ME, chronic fatigue syndrome, that one of the known triggers of ME was vaccines. And trauma, emotional trauma, physical trauma, all these could, but mostly viral, mostly infectious, but it's not just post-viral fatigue. But these can be prevented, all these conditions can be prevented if you get the drainage working before. And the physical signs, I've examined patients' families and found the physical signs in people who are asymptomatic, haven't got symptoms yet, but we can see it's developing. And we can do treatment. The trouble is, Owen, I can't prove that because we get them healthy as everything and they never get ill. And my critics would say easily, well, they weren't going to get ill in the first place. So that doesn't prove anything.
I can see that. Yeah, I can see that's hard to prove. If you had to estimate based on your experience, what percentage of people had their lymph flow going in the wrong direction out of the general population, do you have any idea?
A lot more than we think. A hell of a lot
Yeah,
more.
because CFS is rare relatively, right? Is it 1 or 2% of people or something like that?
Because the thing is that your body can still cope. It adapts, it tries to cope, and it's the coping and coping for years and years. So people might feel a bit fatigued, a bit tired. There's a lot of people out there I have a score, and when I examine patients, we develop a score 0 to 10. 10 being the worst. I don't know, if you had the treatment, you were probably scored at the beginning. If you weren't that severe, you might have been a 6 out of 10 or 5 out of 10. But there's some very severe
I think I was 5, yeah.
Yeah, but some very severe patients are 1 out of 10s. I have patients who have been completely bedridden for years now, 1 out of 10, and we assess how bad they are from examining the patient and going through the symptoms and history, and the physical signs are much more apparent with these very severe patients. But there are some patients out there who are never going to come for treatment. They might be the 8 out of 10. We never see an 8 out of 10 or a 9 out of 10 who have the problem but don't have major symptoms, and they carry on. But they sometimes struggle. If they push themselves too much, they feel it. But they don't think of coming for treatment because they're coping. And eventually one final trigger, maybe a virus, maybe COVID, will hit them, and then they spiral out of control, and then they come to us. And then they go right downhill. So they start maybe at an 8 out of 10 for many years, and then they go right down to maybe a 4 or 3 or 2 out of 10, and then they come to us. So we can spot people who are not symptomatic but have got the problem. We don't see everybody. It would be great if we did. If everybody had the examination and was able to have the treatment, I'm sure there'd be a lot more healthy people around. But again, something I couldn't prove.
Yeah, I know you're a scientist, and so asking you to guess is probably unfair, but I was just wondering, like, if you could guess out of the general population, if you were to examine them, would it be 50%? Would it be 10%? What would you guess would be the percentage of people where it's going the wrong way? Or do you just not know? You have no idea?
I don't know, but I think in some areas where there's high toxicity, high pollution being a big factor as well, if there's high stress factors in wars, in all the things that are happening in the world today, I think that stress is the biggest cause of neuroinflammation. And it's good stress and bad stress, but stress generally. And this would affect a lot of patients. So they have a lot of build-up of stress. And there's a lot of people talking the same language, but in different ways. You've got Robert Navier talking about the cell danger response. You're talking about, there's different people out there who are talking about, traumas of the past causing problems in the future. All these I've got something. They've all got something going on, and it's very important to look at the whole body. And in the past, we go through a very detailed history when we take on patients, and we go through from day one, from birth, and we see all the different traumas, physical, emotional, chemical traumas that can lead to an overload of the sympathetic nervous system and affect the hypothalamus. And then that's usually long before the person gets ill. And then one final trauma is the thing that usually spirals it out of control. So ME doesn't happen from a virus. just by a virus itself. Long COVID doesn't happen just because of COVID. It's the problems there before, and we have to find that. And now a lot of patients with long COVID are being re-diagnosed as ME, chronic fatigue syndrome now, because they've realised that it's something much more than just the COVID.
It's reminded me, like reading your book, one of the things I was really impressed about it is that a lot of people who discover something or create something, and you've done both, they become quite myopic on like only focusing on their thing and to the exclusion of all else. But reading your book, you seem to have a tremendous grasp of the vast amount of different other modalities that are out there, and gave them very fair assessments.
Yeah, I mean,
I,
I'm glad you said that, because there are things that I've missed out, and I've missed out on purpose in my book, because the jury's still out on a lot of these things. But the things I've written about in my book are things that I've tried and tested, and a lot of people have tried and tested. So that's why I've included them. And ME is it's a jigsaw puzzle, and the best thing if there's some take home from all this for somebody who's never heard my work before, it's a take home message in my book. It's talked about in my handbook, my patient handbook, and it's also talked about in my Through the Looking Glass book, as well as the main Perrin Technique book, the big book, which is one you've read, I think, this one here, yeah?
I think so, yeah. Yeah, that's it.
So, so those books all have one thing about jigsaw puzzle, and as I talk about it a lot in the long COVID book, and I look at every single patient like a jigsaw puzzle. I used to love jigsaw puzzles when I was younger, and for those foreign any Europeans watching your blog, I don't know if any do, but if they do, they don't call it jigsaw puzzle, they just call it puzzle. So they don't know what jigsaw puzzles are, the puzzles. So anyway, so to make a jigsaw puzzle, you need the corners first. So what are the corners? The corners of jigsaw puzzle of ME, we look at rest. Patients have to have a period during the day of resting. And this is with fibromyalgia and long COVID as well. A period of total rest, away from everything, away from all activities, away from light, away from sound, just in a nice chilled room, a darkened room, away from everything. During that rest, they've got to relax. Not relax because Dr. Perrin said relax. Relax has to be within, and you have to know how to relax. And some people find it very difficult to relax. So they're lying there thinking, I'm resting, I'm relaxing. That's not relaxing. So they and everybody else as well should try mindfulness, meditation, some form of looking at something beautiful in the room, something pleasing on the eye, or concentrating on something good. There's always something good somewhere. And even if you know it's hard, you should try and focus on the now, and use. And for people who think meditation's a religious concept, it doesn't have to be. Mindfulness can be nothing to do with religion at all, so it's not against the principles of people's faith. So that meditation is very important. So it's rest, relaxation, meditation. But the most important, we started talking about this right at the beginning, pacing. So 50% of what you feel capable of doing. And the way you work it is think, can I do whatever I do, mentally, physically, can I do double? So if you're walking for a kilometre, can you walk 2 kilometres? Or in this American audience, you're walking a mile, can you walk 2 miles? The answer has to be yes. 100% has to be unequivocally yes. If it's too much, if it's more than, if you feel that you can't do double, then you're doing too much. And this protects your body from overloading your sympathetics. So that's number one. So you look at 50%.
Can I address that I've dealt with enough people with chronic fatigue, not nearly as much as you, but you know what they always say when you say that, right? They're like, oh, I feel so behind in my life already. There's so many things I haven't done. There's so many things I wanted to do that as soon as I have energy, I use it all. So and often more, right? So what's your answer to that? And
Yeah,
how do you
that is the
encourage them to
answer
actually
to,
follow
yeah,
that advice?
yeah, because the boom and bust, it's boom and bust. That's what they're doing. And that's going to get them nowhere. If they go over the 50% rule, then they're engaging the sympathetic nervous system more than we want, and we can then go right downhill. And so they can carry on doing that, but they'll never get better. And I know people don't want to hear that, but this idea, when you hear about people like there are out there, people saying you should push, that will destroy most of these ME patients. The people who are successful in helping when they push themselves, they might have a more mental health problem, and that's why it helps them. But ME is not a mental health problem; it's physical. It does affect the limbic system. It does affect the emotional side, but it's not a mental illness. So post-exertion malaise is the biggest symptom, is the main symptom of ME, when you exert yourself. So we ask patients in our questionnaire, when you exert yourself, do you feel better or worse? If people feel better for pushing themselves, they have a mental health problem, what we call an affective disorder. It could be depression, could be anxiety, could be bipolar, could be all. But it's not ME. ME, you get worse, and it might not be straight away. You get worse after. It might be a day, it might be 2 days. So it's been discovered by Stanford University that it could be up to 3 days. 3 days after the actual exertion, they feel much worse. So it doesn't have to. It could be delayed response, but it's mental and physical exertion. So if you try and push yourself, if you get to that level, you're going to make yourself worse and never recover from ME. You just make yourself worse. So we back off. And this is a principle that I've found for years and years and years now. If patients keep to the half rule, rest, relaxation, meditation during the day, but the main rule all the way through your life until you're better, you do half. And as you improve, you can do more. Half of more is still more. So you can increase activity, but you just have to always think, can I do double? And that's always a question. And that's watching television. If I can watch an hour television without any problem, can you watch 2 hours? Maybe that's too much. An hour's too much. Could you watch an hour? Yes, then watch half an hour and watch half an hour later, and then have a break and watch half an hour later. Same thing with walking. If you can walk half a mile, can you walk a mile? Yes, then you can walk half a mile. But then maybe later on in the day, walk another half a mile. And then you're still doing that activity, and you're not reducing that hour of walking. The mile of walking, if you're doing a mile. So all these things can be done, but if you keep to the half rule, you will start increasing activity and you can build up. Now, if you say you would used to be very, very fit and now I'm not doing it and it's frustrating, yes, it is frustrating. My name for ME is TPOS, and it stands for thoroughly pissed off syndrome, which is the best way of describing ME. Patients are fed up. Excuse me, I don't know if I can use that language on screen, but
That's fine on this channel, yeah.
thoroughly
But I get your
pissed off.
point. They're not lazy, right? If anything, they're very frustrated. They can't do more at all
Frustrated, and
times.
they're also frustrated that the doctors don't understand why. Then they say, "Oh, you should be able to do it." And sometimes it's not the doctors; it's the families and people close to them saying, "Oh, come on, pull yourself together, do more. You can do it. Try it once and you'll see." And then they collapse into a heap or get much worse, and then they realise that they couldn't have done it. So we don't want patients to crash. And most of our patients, we keep very strict rules and we stop them crashing. And there's lots of advice out there, but there's lots of other techniques out there that might be necessary, and that's where the jigsaw puzzle comes in. So the next part of the jigsaw puzzle, you do the edge pieces, and that's the Perrin technique, getting your neurolymphatic system working again, and then all other treatments afterwards, like supplements and nutritional advice, and maybe drugs if you need certain drugs, might be other talk therapies and other things. all those are the sea in the sky of the jigsaw puzzle. But you've got to get the corners and the edge pieces there first. Because if you do, then it's much easier to get the rest of the jigsaw puzzle finished. If you start with all the other therapies first and you haven't got the corners, it's a much harder job. So this is why I use this analogy. And some patients are small jigsaw puzzles, 20-piece jigsaw puzzles. As a 5 out of 10, you were probably about a 50-piece jigsaw puzzle. But I've seen patients...
I can't remember if I was 5 out of 10, sorry. I think she told me it was going to take 6 months to get better, so whatever that means.
That 6 months would have been 6 out of 10, that would be.
6 out of 10, okay.
So you weren't that bad. 5 out of 10 usually takes about a year. So this gives us an idea when we find the score. But 1 out of 10s might be a 1,000-piece jigsaw puzzle. And there's a lot of pieces.
In an ideal world, you'd meet all of your nutritional needs in the form of vitamins, minerals, phytonutrients, and more from the foods you eat. However, unless you prepare all of your food at home from scratch using the highest quality ingredients possible, the reality is that most of us need some nutritional support. Most of us need to take supplements if we want to look, feel, and perform at our best on a consistent daily basis. And this is especially true if you have genes that give you an elevated need of certain nutrients. And this is where Feel Younger can help. What I love about Feel Younger is that they offer a huge range of quality supplements and healthcare products formulated and endorsed by Owen Robinson, including must-haves like magnesium glycinate and vitamins B12, D3, and K2. And they do it at affordable prices with free shipping for orders over $50 without ever compromising on quality, purity, or potency. To learn more about how Feel Younger supplements can give your health a boost while supporting this podcast, please visit feelyounger.net and use promo code REJUVENATE to get 20% off your first order. That's promo code REJUVENATE for 20% off your first order at feelyounger.net.
Sorry, out of the things you just said, people are very familiar probably with the do less advice, although your half what you can do thing is good and specific. And people are probably very familiar with, nutritional stuff. But obviously, maybe a lot of people watching are not familiar with the middle thing you said there, which is the Perrin Technique. So could you just explain what it actually is a little bit more?
Yeah, so the edge piece is getting the neurolymphatic system working. So this was what I developed 36 years ago, and I've been working and using ever since. And it's basically a combination of, just swallowed something. So this is a combination of drainage of the lymph in the right direction. So we're pushing down and up, we're going against this backflow, which then causes a concertina effect, or a casein effect, some people call it, where you push up and push down, you create a pressure. And that pressure, pushing down and pushing up, creates a pressure that pushes the lymph into the drainage system like it should be, rather than going in the wrong direction. And this creates a syphon effect, the next physical side. When you have a pressure differential, like you do with a siphon, when you suck up water, it will continue going out once you've created this pressure differential. So we create this pressure differential going down and up, creating this syphon effect into the lymph, into the bloodstream, and eventually into the liver. So this will take the toxins down and up, and it draws by the negative changes, negative pressure, and we create this pressure pushing into this area. It creates a negative pressure everywhere else, sucking up the lymph from the rest of the body, including the spine, including the brain, including the muscles. And muscles get fatigued because there's work done in Newcastle University. Julie Newton and her team found there was 20 times more lactic acid building up in ME patients related to autonomic disturbances in the brain as well. But they found there was too much lactic acid, 20 times more, causing a major fatigue in the muscles. We can drain that away as well by the central drainage. So toxins, lactic acid is important for the body's metabolism. It's actually not bad for you. It's actually good for you, but 20 times more, not. And then we need to drain those toxins away. Otherwise, they end up causing major problems. So there's drainage down and drainage up, and that combined together with manual treatment of the spine and cranial treatment, helping the drainage of the brain and the spine work better, is the Perrin Technique. And we give self-massage routines to help that on the way that patients do. It's all available online, free, the self-massage routines, but it should be done together with a practitioner. But people are going to have an idea about it. But don't do it themselves just by that, because that's not enough. But that's we did just recent research into self-massage for long COVID, and it was very successful. And it was a feasibility study, and it was an NHS project. We've just had word that our work is being accepted to be published, so it'll be out there later on this year. And it was very successful in getting people to do it themselves, but it's not enough. It doesn't help. It helps most patients, but it doesn't help them enough. The treatment together with self-massage and the exercises we give help. So my advice for people is find out. I'm training up a lot of practitioners in the States, around the world. I'm going to Australia in November. I've trained up over 150 American practitioners. I'm now officially attached to a university in America as an New York Institute of Technology. They're one of the largest osteopathic colleges in the world. And I said that I'm now a professor, adjunct professor at the osteopathic manipulative medicine faculty. So I'm very excited by the new prospects of doing new research and putting together a plan. I can't say more than that because we just have our first inaugural meetings, but there'll be a multi-center study into a randomized clinical trial into the Perrin Technique. And that's going to be happening in the near future. We've got research centers set up in different areas, and we'll be doing some interesting scanning, looking at the lymphatics, and we'll also be seeing how patients improve. But with the Perrin Technique, eventually we've shown the diagnostic signs work with a paper that we published in the BMJ. We need more research done into my techniques, and it's always been money. And unfortunately, the most of the funding hasn't been towards me because I'm not a drug. And that's simple. And I always say I don't blame the big pharma for not giving me the money because they're business. They don't want to.
Yeah, I agree. I think I've always thought it's not businesses corrupting government that's the problem. It's governments corrupting businesses. So basically what I'm saying is businesses want to make money, that's fine, but the governments are the ones that should be putting money into public service things like this more, I would say.
But luckily, I've got some good support in the scientific world. I've got my antagonists who don't want,
which is great.
who don't want my treatment to be out there because it's not a drug. It's not a one fix one way. It takes time. But honest to God, Elwyn, I've been doing this 36 years. And you know the famous adage, you can fool some of the people some of the time. And I've been doing this 36 years, and we help most of our patients. That's what I see. And when you have people saying, "Don't go down the Perrin Technique. It didn't work for me." I'm sorry it didn't work for you. Maybe it would have worked if you'd have given it longer. Maybe you did give it a long time and just it didn't work. I'm not a cure-all, and there's no cure-all for ME, but it's definitely part of the picture. We need to get the neurolymphatic system working for these patients to improve. And if we can do that together with other treatments as well, then we can help most patients.
And I want to talk about timeframes, but so you were saying the person really needs to see a practitioner. If they're living in a country that just doesn't have a Perrin Technique practitioner at all, do they have any options?
Well, the book has a whole guide for treatment, and if a practitioner gets the book, they can learn it from the book as well. And if they're osteopaths and they're done cranial, they can have a basic idea of helping the patient, and that's and then we've got the online free videos for the self-massage. But other practitioners anywhere in the world can be trained. I'm doing training sessions all over the world, and I'll go anywhere. If you get a group of practitioners together who want me to train them, I will go anywhere. And I'm doing in November, I'm going to Australia to we're doing 5 workshops, and the Osteopathic Association of Australia asked me to come over because there's so many people there who want the Perrin Technique. In America, it's growing. I'm going next year to Oregon. I'm going to, that's the end of this year, sorry, October, Oregon. I've just been to Salt Lake City, California, I've been. New York, I go every year to train up new practitioners. And we're doing Chicago and we're doing Florida next year. And then that's the end of this year. Next year, I'm going back to Minneapolis. I was there before. And we're doing a few other cities as well. So I will go anywhere that people want me to train up practitioners, and whilst I can. I'm getting on in years. I can do this for a few more years, but and I'm training up practitioners all over, and some are learning advanced techniques and advanced Perrin Technique, where they're learning the in-depth scientific knowledge to be able to teach it. So I'm running courses for practitioners to do advanced, and there are some already qualified, and there'll be more coming in the next couple of years. It's a 2-year course for the advanced. But practitioners, it only takes a 3-day course. If they're osteopaths or any manual practitioners who've done cranial can do my course. So if they've done up ledger, which is a cranial for non-osteopaths, they can do my course, and I'll train up people anywhere. And I'm not.
So the best bet, if you're in a country, say, or a location with no one, in hundreds of miles or whatever, is to seek out an osteopath or craniosacral therapist and try and persuade them to learn this. And as you said, they can learn it fairly quickly, at least the basics of it.
They come to one of my workshops around the world, or they can bring me over there. And the patient, I've done that in quite a few places where I've gone to the patient and we've trained up practitioners and I've taught them what to do, how to treat them. And we've had some amazing successes around the world.
And how would you compare the effectiveness of something like lymphatic drainage on its own? Is it,
no, that's different. You see, general lymphatic drainage works on sluggish lymph or lymph that has been damaged. So they want to stimulate the lymph to work more. With neurolymphatic problems, the lymph is working in the wrong direction. So you do standard lymphatic drainage techniques, often it can actually stimulate the lymph to work more in the wrong direction. So
is this a possible explanation why some people feel worse when they have lymphatic drainage? It's not like detox or whatever. It could be because it's making it worse.
Yeah, most patients feel worse when we start treatment because we're draining off toxins that have been stuck in the brain. When it comes out, they feel worse, so we expect that. But if patients get worse and worse and worse, that's a problem. In my early days, when I realized the lymphatics were involved, I was doing some techniques which we call abdominal pump, thoracic pump techniques that have been done in osteopathy for years for lymphatics, and my patients were getting worse and worse and worse. And I thought, I know the lymph is involved. Why are these techniques making these patients worse? And then the penny dropped. I realized that it's backflow of lymph. That there is a pump technique of the lymphatics. There is neurological control of the lymphatics. When I learned that, then everything changed. So I teach lymphatic courses around the world for undergraduates, especially in Europe. And when I teach the standard lymphatic drainage, I say, right, we've done that for lymphedema or for lymph problems where there's damaged lymph, or where there's sluggish lymph. And we want to stimulate healing and we want to stimulate lymph to work better. But now we're going to learn all about the neurolymphatic system. So scratch everything I've told you, we'll start again. So it's a bit of
right.
Yeah. And they go,
well, that's important information, right? People can be doing a lot of things thinking that they're making themselves better.
For instance, the lymph drainage of the breast tissue should be in the axilla. A lot of it, 75% goes to the axilla, to the armpit. If you did this with ME, with ME patients, you just get swollen armpits, which we have seen with patients who don't do it right. So they never go towards the armpit, they go up towards the collarbone, to the central drainage. We never go to lymph nodes, because that would just swell them up, because it's going backflow anyway. So we want to drain it away from there and going up. So this is a major factor. If you did standard lymph drainage in many of these patients, it would make them worse, actually make them worse.
What about other activities that are often recommended to get lymph moving, like rebounding, trampolining, hot saunas, or whatever?
Yeah, all that would be making things worse, because it stimulates the lymph to work more, and if the nervous system is pumping it the wrong way, it'll make more again in the wrong direction. So, I
Okay.
haven't.
And so
Yeah.
even
So
exercise. So is this one of the reasons why people with the CFS feel worse with exercise? Is it's encouraging more lymph to go in the wrong direction?
yeah, that and it's overloading the sympathetics. It's pushing the strain in the body. Once they're on the mend, we do recommend certain activities, and one of the best ones is sculling and on the swimming on the back, just gentle motions with your hands, gentle legs up and down. But that's when you're well on the mend. But you're not going to exercise your way out of ME. This is what we were fighting. I was fighting this. I was the only one in years ago was standing up on the rooftops shouting, saying graded exercise doesn't work. I got vilified by the NHS because of it, because I was attacking what they were saying, and the doctors were saying no, 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 and I was saying rest, pace. And now finally NICE has agreed that you need to pace. And the thing is that you're here in this country, you need to pace yourself, and they say 70% rule. How do you work out 70% rule? The only thing is, I think that if they said 50% rule, they might have to quote me, and God forbid the authorities would have to quote me 50%. But in America and the rest of the world, they all say the 50% rule now. So that's some of my work has found out there around the world, but not in the UK. It's 70% in the UK. You work that one out.
So actually, could this be another way you could, like, that gives an indication to anyone listening or watching that their lymph is going in the wrong direction if they feel worse with those kind of activities consistently? Is that
It
like
could be. But if they get examined by somebody who knows what they're examining for, they can find out straight away if there's problems, because they'll have these 5 signs, definitely. And we've seen this with long COVID. So with long COVID, as soon as we started identifying it very early on in the pandemic, we were treating long COVID. We didn't stop one day. I had masks, I had visors. I changed my clinic tunic for each patient. I scrubbed up. We kept the practice going because we needed these patients. We knew that if they got COVID, they'd go downhill. We needed them to stay healthy. And we kept open, and not one of my patients ended up hospitalized. Not one of them ended up dying. We were told we're going to kill our patients. Nobody. My practitioners didn't. We kept them going. And what we did also, we helped, and we published papers on long COVID showing that we were helping. And this was done through the University of Manchester. And now we've done this research showing that self-massage alone can help some patients, and that the feasibility studies showed that they were engaged in it. And that was just the self-massage, which the NHS love because it's free. So, yeah.
Yeah, okay, from their point of view, yeah.
Well, the difference in America and I say you have a lot of Americans. The difference in America and England, I heard this from another doctor. It's very funny, but very true. He says in America, it's how much money you can spend. That's what medicine's all about. In England, it's how much money you can save.
Yeah, 100%. My experience would definitely go with that. Let me just ask you about mitochondria before we finish, because generally with CFS and energy, there's a lot of focus on mitochondrial health these days, as if that is the the place that we should be looking, and the cutting edge and all the rest of it. There are even tests for mitochondria these days. I've done it before. What's your view on assessing the mitochondria? Is it helpful treating the mitochondria of all the kind of treatments that people do? What do you think?
That's a good one. Yes and no, yes and no. There's lots of yes and no. Right. Mitochondria are very important. We know that. And there's lots of doctors out there, Sarah Myhill, and there's Robert Navio, that all talk about, and there's a methylation cycle. There was some amazing doctors and scientists I've met over the years who talked all about the mitochondria. It is important. They are the cell production parts of the cells. But if you look at the bottom line, what's the main raw materials for the mitochondria? Forget all about the different methylation cycle and the citric acid cycle, but the main two, you need
oxygen and glucose.
Yes, oxygen and glucose. You need those two. Those are the raw materials. Oxygen, you need to breathe well. You need circulation. You need the blood to transport the oxygen to the cells, and you need good metabolism working to get the glucose to the cell as well. So how do you do that? Well, if your autonomic nervous system doesn't work properly, if your hypothalamus isn't working properly, it won't happen. You won't get the oxygen, you won't get the blood flow, you won't get the oxygen to the blood and into the, you won't get the glucose metabolism. The hypothalamus controls metabolism. It balances everything. The autonomics control blood flow, control breathing. So all this is related to that. And, even when you look at the cell danger response of Robert Naviaux, he talks about the autonomics being so important. And that's why. And I talk about in a more systemic point of view. You need your autonomic nervous system working well. You need the hypothalamus working well. Once you get that working properly, you get more oxygen to your blood, you get more oxygen to the cells, you get more glucose into your blood, you get more glucose to your cells, and you end up with good mitochondrial function.
That makes sense. I have to say, from my experience of testing mitochondria, it was interesting. But the kind of bottom line conclusion of it is like they're not working properly because of something, and it looks like toxic exposure. And sure enough, that's been proven in my case. So it kind of goes back to what you said, right? If there's high level toxicity, then the mitochondria are not going to work as well. And as you just said, is there's autonomic regulation, the mitochondria are not going to work as well. So these are like root cause things to address ultimately.
Yeah. And that's what we do, and that's what we address. So once that works, you see, if it was that, none of my patients would recover unless we gave them lots of these supplements. And sometimes you don't need these supplements, the patients will recover. Sometimes they need a bit of an extra kick, and that's the sea in the sky of the jigsaw puzzle. Working on the methylation, working on the mitochondrial function, and giving supplementation and all the rest of it. But you don't always need that. Sometimes easy cases, you won't need that at all. And sometimes there's major mast cell activation, there's Ehlers-Danlos and POTS and all other comorbidities that we see, all related to the fact that the lymph isn't working properly and the neurolymphatic system isn't working, and you can relate that to all these conditions. So once we get that neurolymphatics working, most of these conditions are helped, but it takes time, and I haven't got a quick fix, unfortunately, and that's another thing that they don't like, because it takes a long time for patients, and that's the thing.
Yeah. Could you guide us on that? So what's the kind of range that you see for, let's say, full recovery? I know you said you can't guarantee full recovery, but you say you see
we
a
have
lot.
there's some. We did a study showed that 90% of patients. This was a study done internal quite a few years ago, where we actually looked at a whole group of patients, a few hundred, and we saw 90% of patients improved. So of the patients who had the treatment, 90% improved, and we had about 15% of patients got completely better. Now that's completely symptom-free, 10 out of 10 on the scale. That might not seem a lot, but there was an international study done that showed that only 2% of patients with ME get completely better. This was done by a Norwegian group, and we have 15%.
Well, the thing that occurs to me is how many of the general population are walking around at a 10 out of 10. That's not super common either, right?
Exactly. And 10 out of 10 means they can do everything they could do before, and they can do anything without any symptoms at all. So it's very rare to get to that. But we get a lot of patients.
When I say full recovery, I just mean back to the level of the average person then, which is what, a 7 or 8 out of 10.
Well, we have a large number of patients that get to that. I don't know exact number, and that's what we're going to do the study to show. We showed 40% of patients improved in the trials we did at the University of Salford. We had it was a controlled trial where 40% of patients improved by 40% of health in the year. So a lot of patients need longer than a year, but in the year that we did the trials, we had a control group that were given any choice of any treatment, and they showed a worsening by 1%. They could choose anything they wanted, and our patient group improved by 41%. It was improved. So that was over 1 year from their level to improved. So some of them were symptom free completely. and some of them were had, but they overall showed a very markedly improved, and that improvement in the symptoms. And this was in my thesis, in my PhD thesis, and was published many years ago in the 90s.
Is part of the challenge that once your lymph is sending things in the wrong direction, it's very hard to get it to consistently always send it in the right direction?
Well, yes, and also we know about the SLIM. The SLIM is an area of the brain that was discovered only a couple of years ago, where the membranes of the brain, the meninges, we always believed was just the dura, the arachnoid, and the pia. In the subarachnoid space, there's an extra layer called the SLIM, subarachnoid lymphatic-like membrane, that is only one cell thick, can get easily damaged by trauma, and it's down the spine as well. And this area can be damaged, so therefore, as the toxins drain away with our technique, some of it drains back into the brain and back into the spinal cord because of the damage of the SLIM. So this has only been newly discovered. So we're going to be looking into this in research in the future with our scanners and see if we can see changes in that. But that could be a major factor why some patients don't get fully better, because they've had too much damage to the spine or too much damage to the brain, to the skull, to the cranium, and affecting this SLIM. So that could be why some patients don't get fully better, even however much they try and get better. So then we need to, and I have patients that come in every few months for further treatments. So they come maybe for checkups or for top up, and every few months they come in and I keep them going. So they can get to a certain level, and sometimes they can't get any more. Some patients, they don't need to come, but they still do for 10,000 mile service, I'd say. But
Yeah, that's what we were talking about early, like getting into more preventative mode is always wise. Another practical question, if you don't mind, on the subject of fatigue. So a lot of the time, in the whatever you want to call it, not mainstream community, fatigue is kind of addressed with thyroid support, right? Either T4 or T3
yeah,
or
I mean,
some
the thyroid
combination.
is going to be affected, yeah.
Yeah, it's okay. So yeah, as I say, the effectiveness rate of it is fairly high. It's not foolproof. Again, there are some people it makes them feel worse or whatever, but it's pretty effective for a lot of people. So,
And the
what's your
adrenal
view on
glands
that
as well, in the
approach?
adrenal glands as well. The thyroid, the thyroid and the adrenals. There's Barry Peatfield found a lot of work, a lot of interest in the adrenal glands. He was a doctor that said it was a lot to do with adrenal problems. It's going right back to the hypothalamus. The hypothalamus controls the hormonal system, so it controls the thyroid gland. It controls via the pituitary. So if the hypothalamus goes wrong, the thyroid's going to go wrong in a lot of these patients. So sometimes just by supplementing the thyroid, if they've got hypothyroidism, you get thyroxine in, and sometimes the opposite. This happens in patients with ME quite often as a result of the hypothalamus not working properly. So once we get the hypothalamus working, it's very important to have a T4 or T3 test again to see if there's any thyroxine or thyroxine levels might change with the treatment, because the hypothalamus might be working better. So it's always important we tell patients, go back, have your test again, because you might not need the thyroxine as we treat. Yeah.
Okay, well that makes sense. So I guess the question I'm asking is, so with all those kind of hormonal supports, which I know a lot of people are very ambivalent about, whether it's thyroid or progesterone, or you just said, cortisol potentially, whatever. It can make people feel better. It can make them function better, as you just said, at least temporarily. Is it a good idea? Do you think it gets in the way of treatment? Does it support treatment? Is it neither?
I think that everybody's individual. If you try and it helps, then fine. I mean, with anything, I say, if you want to try any sort of modality on top of my treatment, if you feel it helps, then and it doesn't, and the doctors are happy about doing the treatment together with my treatment, I'm happy to go ahead. as long as it's not going to overload the sympathetic nervous system. That's the difference. So some drugs like beta blockers are given for patients like with migraine. I'm not so happy about the beta blockers because it can affect the sympathetics big time. So, you have to be careful. I'm not saying stop beta blockers if it's helping, but if it's not helping, it could be because it's aggravating the sympathetics.
Okay. So something like Adderall or Ritalin would be less encouraged.
Yeah, there's certain and there's certain antidepressants that work better than others. If somebody finds an antidepressant that works, sometimes it's better to take something that does stimulate the sympathetics in some way, like the like SNRI rather than SSRIs, because sometimes it can boost them in the mornings. It can give them a bit of a boost, but everybody's different, and I'm not for advocating this treatment or that treatment. I just say every single patient is different, and some need more than what we can do. A lot of them do, and as they find something that helps alongside what we're doing, there's a lot of talk about low dose naltrexone nowadays for ME and fibromyalgia and long COVID. Now, it can help some patients. Some people it doesn't help. So everybody's each to their own, and there's no one set pattern and medication or treatment that works alongside mine, except we know that if patients follow my treatment, it will help other things that they're doing as well. And we've seen this again.
That makes sense. Yeah, and as I said, that's one of the things I like about your approach. It's very non-dogmatic. It's whatever works, whatever helps. You do say in your book that alcohol is pretty much always a bad idea.
Yeah, 100%. And that's because of what we know in neuroscience, and not because of the liver. The liver, we need the liver to work. So you don't want to overload the liver with toxins, and alcohol's a major toxin. It's the two areas of the brain that two chemicals in the brain, neurochemicals that are affected most by alcohol are GABA, gamma-aminobutyric acid, and NMDA. Now, NMDA receptors are found in the thalamus, and they've been indicated in stimulating neuropeptide P in fibromyalgia and in ME. So NMDA receptors are very much affected by alcohol. So if you have alcohol, it will affect those receptors, and it can really damage the actions of the thalamus. And secondly, the GABA in the basal ganglia, they can be affected because that will dampen pain, and they can be affected. The alcohol can affect the GABA, and GABA is very important for lots of things, sleep and relaxation, and other things involved in the brain's function. Now, the hypothalamus is right next to the thalamus and the basal ganglia. The basal ganglia include a lot of they're all part of the limbic system, so it affects the emotional side. And these parts have been indicated when they first discovered the glymphatic system in 2012 in mice. When they stopped it from working, they found the toxins building up in the basal ganglia and the thalamus. That's where the first port of call of the drainage problem. So if you take alcohol and stimulate and you affect these chemicals, it's going to affect those areas of the brain that are the main areas of toxins to begin with. So we don't want to add further toxicity to that area. We want to keep that area as healthy as possible. So alcohol is an absolute no for these patients. Yeah.
Is there anything else in that category? As you say, a lot of it is, context dependent, but is there anything else that you just warn people this is always a bad idea?
Reduce gluten, reduce milk, that's casein in the milk protein, and reduce sugars and yeast, because they're large molecules. The yeast, the casein, and the gluten are large molecules that need the lymph to drain away from the gut. So you do not want to overload the gut. And that's a very important part of the drainage of the lymph. The gut, we need the gut to work as well as possible. And that's why a lot of patients get irritable bowel, they have problems with the microflora, with the microbiota, we now know that 75% of all neurochemicals are produced by the gut. So, and there's a link between the vagus and the brain and the gut that is going to be affected if the gut doesn't work properly. So we want the gut to work as well as possible. and that's the lymphatics are needed to work and they're not working. So you don't want to overload your gut with large molecules. So gluten should be reduced, casein should be reduced, that's milk protein, milk products, and yeast. Don't stop totally, because then you can end up not producing enzymes that need to use to break them down, and you can become allergic to these things. So cheat occasionally, but reduce them.
Okay.
So that's another advice from a nutritional point of view. But the main thing is the jigsaw puzzle: rest, relax, meditation, and pacing. Do the neurolymphatics, get that working, and then all the other things that you need. Yeah.
Excellent. And you have a lot of guide to all those other things in your books as well.
Yeah. Absolutely. Yeah. But everybody's
Fantastic.
different. Everybody's different. So hopefully that will help your listeners, and hopefully you understand it a bit better, Alan.
Yeah, I thought it was very interesting, very helpful. So we've recommended your book several times, but if people are interested in learning more about you, they can also go to your website.
The end of this year, there's a listening book coming out for people who can't, because a lot of people can't read and they find it difficult. So the patient handbook we're having the listening. It's going to be a talking book coming out at the end of the year, and Betty Ross, Jonathan Ross's daughter's doing the Audible for us. She's going to be
nice.
She's one of our successes. She's one of our well-known successes. So she's going to be doing the Audible for that. So that's exciting times ahead.
Fantastic.
So that's going to be good. It'll be out at the end of the year, by the end of the year, definitely. So that's good.
And if people want to find a practitioner, I was going to recommend if they go to the perrintechnique.com.
And they've got the map and then if they haven't got anybody there and they want desperately, get in touch with practitioners. If a group of practitioners they get together, want to bring me over, I'll go anywhere in the world. Anywhere.
Awesome. And there's also a self-help guide on the site. There's workshops, how to become a practitioner. So all the information you need, if that's of interest to you.
Is really useful. Yeah. Because a lot of people get
fantastic.
So it helps them with their exercise. Do it the right way. They should watch that, but they shouldn't just use that by itself, because they need to see a professional as well. That's important. Okay.
And you talked about upcoming research studies. Is there any way for people who are listening or watching to participate in those, or is that how does that work?
We'll let people know when it's all up and running. There's a lot of work behind the scenes, but it's going to be in America and the UK, and it's going to be a multi-center study, and it's going to be exciting. Yeah.
How would people register their interest for that if they wanted to do that?
We can come back. I can come back another time and let you know about that. I can let you know when watch the look at the website, because our website will tell you when it's up and running, and we'll have the major news. So we'll be making sure people know about it. Yeah,
that's very exciting. Well, thank you very much for your time, Dr. Perrin. Very much appreciate having you on. Anything else you want to say before we close?
No, just remember that it's not a quick fix. There's anybody that offers do this 1, 2, 3, you're better, just stay clear of. There's no quick. I'm not going to mention any names of things, but there are people out there saying 3 days of this and you're better. No, it doesn't work that way. I wish it did. We're dealing with chronic illness. These are the things that have taken years to build up in your body, so they take time to get out. But if you follow,
I agree.
If you follow, if you follow everything we tell you, it will help. Definitely, we've seen it work again and again.
I personally think it's harder to diagnose, but this is in a way more difficult to treat than a lot of things like metabolic syndrome, maybe, that are much more recognized. It's pernicious and it's hidden, but that doesn't mean that it's not a difficult thing with deep roots that take a while to address, unfortunately.
When people actually listen to me or read my book like you have, Owen, they all say the same. It makes sense. But the people, my critics who don't advocate my work, they've never read my full book. They've never listened to me and talk and tell them that what I'm saying. They just straight away they see me as the enemy, and this is a problem in this country. In the UK, we have this. Unfortunately, they look at me as the enemy, And they're not listening to what I'm saying. I'm saying I haven't got the cure. I've got a treatment that helps most patients, and we know why, and the science backs up now everything I've said. And they just should listen to it. It's a shame they
Yeah.
don't. Yeah, but
And also try it. I'm a big fan of trying things, or if you don't have a problem, you know, having your patients try it, right? Just see if it works or not. Yeah.
Okay.
Okay.
Good luck with
Thank you so
everything.
much for your time. If you're watching on YouTube, you can feel free to leave a comment underneath. I'm not sure if Dr. Perrin will see it, but I will. Remember to like and subscribe. And if you would like Dr. Perrin back to talk about his latest research products, whatever, let us know in the comments again. Thank you, and see you next time. Hey, thanks for watching the video. If you enjoyed that, I recommend watching our latest episode, which you can do by clicking above. And make sure to subscribe, like the video, comment, and share with anyone who you think might appreciate it. Thank you.